in your clinical practice, how do you address the following treatment hurdle? That oftentimes when I suggest to patients that they try an atypical antipsychotic agent for depression, they're very hesitant and reluctant because they wonder how the label of psychosis and antipsychosis will apply to their case, which of course clinically we know is not relevant to their case. They're not psychotic and they're not, they don't require an antipsychotic for its antipsychotic benefits, but rather its antidepressant benefits. How do you handle this situation with the patient?
That's good. It has gotten better. And what I mean by that is initially when we started utilizing these medications, the stigma and the name was there. And many patients still today are reluctant once they hear that. Part of it, I think, is this categorization of the medication as an antipsychotic. And in essence, what needs to happen is an education with the patient. Before you even write the prescription, discussion of what are the available options and what you are thinking about prescribing them. And one of them is this medication of this class. This is what they're referred to, but I emphasize to the patient that they have indication as add-on to antidepressants for treatment of major depressive disorder. As a matter of fact, most of them have indications as mood stabilizers for treatment of bipolar disorder. So this category of medications tend to be more work as a mood stabilizer as well. And this is the second time saying it, give him an aspirin analogy that first it came out as an analgesic, but now it's used for multiple other reasons. So to educate them so they know what the medication is, what's the purpose of utilization. Sometimes we even discuss dosing parameters that for psychosis it's used at this dosage. In case of depression, this is the dose parameter. And also warn them that once they go to the pharmacy, they may get a printout sheet that says this medication is for schizophrenia. I again reassure them that they do not have schizophrenia. Their diagnosis is major depressive disorder, and adding the medication on is to enhance the outcome.
Dr. Jackson, in your clinical experience, when you feel that atypicals could be indicated or other adjuncts could be indicated, but let's focus on atypicals since they're the on-label interventions. How is it helpful to kind of frame the risk versus benefit discussion? What's a helpful way for clinicians to approach informing patients about the risks and benefits in a balanced and informative manner?
So with respect to adverse events, paradoxically in primary care, when we're talking about the atypical antipsychotics, specifically the metabolic adverse events that are potential, my patients actually fear that less, unless we're talking about weight gain. They're concerned about weight gain because of their appearance sometimes. But in terms of, my cholesterol, I'm already monitoring that anyway. Okay. And many of my patients are already on treatment for hyperlipidemia, or we're monitoring their glucose levels. And so the impaired glucose tolerance that may be caused or a part of atypical antipsychotic therapy is less concerning actually for my patients sometimes. Now that doesn't mean it's less concerning for me, but that's not so much a barrier for them. We do have to address this label issue of antipsychotic, because if they find out this is an atypical antipsychotic from the pharmacist or the pharmacist printout and they don't find out from me, they're not going to take the therapy most of the time. So I need to address that with them, just as you said earlier. With respect to the akathisia and EPS, extrapyramidal symptoms that can be present, patients do fear that. They will read that and find that on the label. And so we sometimes talk about that, and I warn the patients about it. I tell them that it could happen. But I find if I address those fairly easily, and I say these are the things that you might read about or might happen, but these are the things that I've seen in my practice, and I pick out some of the more important ones to patients or that I see more frequently, and I say, look, if you have any problems, please call me. That usually takes care of it. What I find is if I tell them the 25 things that are on the prescriber information label, the patient's overwhelmed. But if I don't tell them anything, and they read it and they find out, then they feel like it was bait and switch. I sold them a treatment and I told them all the good parts, but I didn't read the fine print for them, and they feel duped, honestly. And that I don't have a study to show that, but in my clinical practice, if I don't talk about some of the adverse events, they feel tricked and they won't take it.